Hello and welcome. This is Dr. Anil Joshi welcomes you to my series Learn Radiology with Dr. Anil Joshi. Today's lecture topic is based on the barium enema study. We are going to see how a barium enema is done, what are the procedure details, and how to interpret the pathologies. We are also going to see which pathologies can be interpreted with the help of barium enema. Now let's get started. Before we go to the topic, first the disclaimers. The material which we have used is almost from our own departmental as well as my personal private practice. Certain slides are borrowed from the net which are freely available and they are without royalty. So we do accept that certain material has come from the net, but it is free of the royalty and there are no copyrights over it. We acknowledge them with thanks. Now let's go to the topic, radiological evaluation of the large bowel pathologies. Now the first are the X-ray anatomy of the large intestine. A large intestine has three parts. A cecum, which forms the vermiform appendix, which is attached to the cecum, a colon, descending colon, transverse colon, and sigmoid flexures, along with the rectum. So these are the gross anatomical divisions of the large intestine. Now what are the indications for barium enema? Are the suspected ulcers, benign tumors such as polyps, then appendicitis, diverticulitis, then polyp, cancers, valvulus, then necrotizing enterocolitis, then GI hemorrhages, then chronic diarrhea, blood in the stool, then constipation, as well as irritable bowel syndrome are the indications, along with unexplained weight loss where you are suspecting malignancy of the large colon, then a change in bowel habit. Suddenly there is a constipation, diarrhea, or alternating both the things, and suspected blood loss to the stool, that is the melena, which is suspected clinically, and we try to source the source from where the hemorrhage has come. Now, what are the clinical indications? The right and left ovarian quadrant pain, then fever, then distension, obstruction, weight losses, then positive occult blood in the stool are the few indications to enumerate. Though earlier we have given you certain more indications, these are along with it. Now what are the contraindications? The contraindication include toxic megacolon, recent biopsies, rigid endoscopy within 5 days before the investigation, or flexible endoscopy within the 24 hours. Please note, if it is rigid endoscopy, the gap is 5 days, and if it is a flexible, then the gap is of 24 hours. Now generalized peritonitis is another contraindication because there are some chances that barium will leak and cause further damage to the peritonitis. Now what are types of barium examination? Double contrast examination, the method of choice to demonstrate mucosal pattern due to good mucosal coating, then single contrast barium enema, then there are certain advantages of double contrast as well as single contrast examination. In double contrast examination, it's a method of choice to demonstrate mucosal pattern due to good mucosal coating. Then in single contrast, it's a simpler, shorter, does not require vigorous maneuverings and can be quickly done, do not need expertise to perform it, and there are no chances of failure because in double contrast, sometimes when you are maneuvering a column of barium and air, there can be a misleading picture. Now, the preference in young patients and very old patient and very sick patient, disabled patient is usually performed as a single contrast examination. It is also done in suspected cases of obstruction and evaluation of distal colonic or colostomy cases. Now, aim of the single contrast barium examination is to achieve a homogeneous barium particulate suspension throughout the bowel lumen In other words, there has to be a homogeneous column right from the sigmoid colon up to the rectum. It should be continuous without break, and it should fill the large bowel properly. The basic principle is that all the segments of colon should be clearly seen within the overlapping loops. Now for that, there are different projections which we are going to see in this study, and also we have seen it when we have seen the other studies that multiple radiological positions are required when we are dealing with overlapping loops, maybe a oblique, maybe a compression, or maybe a lateral projection. Now each and every segment should be seen in barium enema in at least 2 films. For that you have to adjust the patient, adjust the barium column, as well as improve the technique so that it will be clearly seen. Now this is done by a combination of fluoroscopy, a compression spot film of the entire colon. Fluoroscopy is required to guide a barium column which starts from the rectum and ends into the cecum. So for single contrast barium enema, low density barium suspension, that is 12 to 25% weight by volume, and a KV range of 100 to 110 is used. For double contrast, it is high density barium suspension, that is 60 to 120% weight by volume, and the KV range is slightly lower, that is 90 is used. Radiographic technique differs from center to center as well as from machines to machine. Our practice is not to exceed 100 kVs in any of the studies, and we keep our KV range in the range of around 70 to 85, and we never exceed 100. However, it is a institutional practice and can differ from center to center. Now, how we prepare the patient is to obtain history of recent illnesses or other medical conditions. Then, on prior night, patient has to eat a low residual diet and drink a lot of waters. Patient can take laxatives. If he is already used to the laxatives, he can take same laxatives, or he is advised laxatives additionally. Now, barium enema, we need a good bowel preparation. When we take a plain X-ray, if we find that bowel preparation is not good, again it is top up with simple soap water enema before the examination to get the impacted fetal matters. Now, women should be asked always, that is always, about the missing dates or the suspected pregnancies. This is thumb rule for any of the radiological procedures. Now the procedure. The lower GI examination is usually done on an outpatient basis. The patient is positioned on the table and a scout film is taken to confirm bowel preparation, and if not, the remedy as advised before is applied. Now a small rubber tube is then introduced into the rectum and 200 ml high density barium diluted in water is introduced. Now the infusion is terminated when the barium reaches the hepatic flexure. So till barium reaches hepatic flexure, we keep on installing the barium suspension. Now, followed by this, since we are doing a double contrast examination, air is introduced which is gently pumped into the bowel, forcing the column of barium which is ahead, and it should remain ahead, and a air column or introduced air should not cross barium to give a proper mucosal coating and to obtain a proper double contrast examination. In some circumstances, water or iodinated contrast is preferred than barium, and these conditions we are going to see when we are going to go for a film reading section. Then inflated rectal balloon catheter is used only if necessary, because there is a high or added risk of perforating barium, and this is usually used in debilitated patients or in elderly who cannot hold barium. Now, intravenous injection of Buscopan 20 mg or glucagon 20 mg may be given if the spastic segment or annular malignancy is to be differentiated. If you are suspecting a spasmodic segment or a segment which is not distending, give patient IV Buscopan or glucagon. If it is malignancy, the segment will not distend, or if it is a spasm, then the segment will get distended. If it is projectional, then your oblique or compression film will differentiate. So it is extremely important to follow a proper technique of radiography. For films of all the areas of large bowel are taken, including oblique views. Now for rectum, PA and left lateral are the best views. However, what we feel for rectum is the best film is the lateral film, which gives the best information about the rectum and the distance between the rectum and the sacrum, which is pathognomonic of certain pathological conditions. Now for sigmoid, left posterior oblique and right lateral projections are of the choice, and for splenic flexure it is right posterior oblique. Hepatic flexure, it is left posterior oblique position which are preferred, and for cecum, AP and left posterior oblique are preferred. However, often we need compression to separate cecum from the overlapping small bowel loops. Now, by maneuvering barium ahead and air behind, films are obtained so that entire colon is well visualized. Now, here also we can maneuver a patient in such a way that in certain films there will be air containing, and in some film there will be barium in the suspected area. Now, Bucky overcouch film is taken to confirm the coating of the colon, and once it is done, then the patient may be repositioned frequently in order to image the colon in several angles, including erect and decubitus. When the examination is complete, post-evacuation film will be taken. Now, quality control of the images. The mucosal coating, which is in turn depends on the barium suspension and a technique. A good mucosal coating is needed for interpretation of the pathologies. Now, distension. It should be just adequate. Distension should be monitored, it should be controlled, and should be adequate to see the normal folds. The projections are ideally without any overlapping of the loops and with lesions in profile. So we take oblique and compression films whenever required, standing or in supine. Now, a lower GI study is usually completed within 30 to 60 minutes. This is the individual practice and it can differ from study to study and from patient to patient. Now, X-ray images of the lower GI tract is a minimally invasive procedure with rare complications. A radiology examination such as the lower GI can provide enough information to avoid unnecessary colonoscopy. In other words, it can also give a clear indication whether patient should go for a colonoscopy or not. So it is a very important indication before colonoscopy and to take the hints from the barium enema of the colon. Now, because barium is not absorbed into the blood, allergic reactions are rare and no radiation remains in patient's body after the X-ray examinations are over. Now, these are the few things which we must know. Is it that barium examination is free of risk? Yes, barium is inert. However, the procedure can have certain disadvantages. Now, there is a negligible radiation risk. Let's see how much radiation really is given during the barium enema examination and how much really we are receiving routinely without doing anything. Now, the effective radiation dose from the procedure is about 4 MSV, which is about the same as average person receives from the background radiation in 16 months. Now, a rare case is the barium could leak through the undetected holes in the lower GI tract, producing inflammation in the surrounding tissues. Even more rarely, occasionally, the barium can cause obstruction in gastrointestinal tract called as barium impaction. Now, the side effects of pharmacological drugs which we are using as a buscopan and glucagon can cause blurring of the vision, but it's a temporary, not to worry about, and give patient adequate reassurances. Cardiac arrhythmias due to rectal distensions are known, but it can be monitored properly. Now, hypersensitivity reactions to the barium are extremely rare and we have not seen them till today. Now, constipation can occur because of two things. One thing is because of the impaction of the stool, and second is coating of the barium over that because it is a high density barium. If it is used, it can cause a hard stool. Now, perforation can occur, or invasion of the barium into remain is a theoretical complication which we have never seen, and buscopan has got its own side effects which we have discussed. Sometimes it can be even retention of the urine, and they get resolved on its own and do not need much of the care. Now, let's go to the patterns of pathology over the barium study. First is the surface pattern. Second are the fold pattern. Third are the protruding lesion. Fifth are the depressed lesion. Then are the counter abnormalities. All these patterns are discussed and they are illustrated in the films which we are going to see subsequently. Now, appearances of pathologies on barium enema. Depressed lesions are the lesions that extend beyond the normal contour of the bowel, such as ulcers or diverticuli. When located in the dependent surface, they trap the barium and therefore are seen as the focal barium collection. When located in the independent surface, they empty barium. If there is adequate coating of the side of the depressed lesion, it is then seen as a ring lesion or ring shadow. Now let's move further. What are the large bowel pathologies? They are inflammatory bowel diseases. Let's consider them one after another. One is Crohn's lesion. It's a chronic, idiopathic, relapsing, inflammatory bowel disease. Then it commonly affects the right colon and the terminal ileum, so-called backwash ileitis. It can involve any portion of bowel with the development of the ethmoid ulcers. Then ethmoid ulcers have a discontinuous distribution, that is, these are the skip lesions, producing classical cobblestone appearance on the barium studies. Now, complications which are associated with Crohn's lesions are bowel obstruction, toxic colitis, abscess formation, fistula formation, phlegmons, fibrofatty infiltration of mesentery, and colonic carcinomas like or otherwise. In addition are the lymphoma. Second are the ulcerative colitis. It has a relapsing course of chronic inflammation and extra-intestinal manifestation. The intestinal inflammation is limited to the colonic mucosal layer and typically involves the rectum. Rectosigmoid junction is the first to get involved, and from there it spreads almost to entire colon in a different stages. But in initial stage, it is at the rectosigmoid junction. It may extend proximally. We are continuing ulcerative colitis. Earlier changes are noted at rectosigmoid junction, as we have seen as an imaging feature. The initial stage barium enema could be normal. There may not be any evidence of ulcerative colitis. Further involvement of the large bowel indicate progress of the disease. Now, if you are finding that further large bowel is involved, be sure that disease is spreading. After entire large bowel involvement, even the terminal ileum is also involved, and it is called as backwash ileitis. It is same as that of the Crohn's lesion. One of the complications of ulcerative colitis is bacterial superinfection leading to toxic megacolon. Now we are continuing with ulcerative colitis. Further, the plain radiographic may reveal mural thickening, that is thumbprinting. It's a very good radiographic appearance. Double contrast enema is required for details of mucosa, strictures, then granular appearances. There is bowel shortening, loss of nostrations, and intraluminal narrowing. These are the features we see on a barium enema studies. Button-shaped ulcers are noted when almost all mucosa is destructed. So this is a sign when all mucosa is destructed. there are pseudo polyps. Further, what are the extraintestinal manifestations? They include arthritis in most common presentation. Second is uveitis, episcleritis, erythema nodosum, and the liver diseases are few to enlist. Then long-term ulcerative colitis patients have increased risk of developing colorectal cancers. Then colonic strictures, which develops from repeated episodes of inflammation and muscular hypertrophy leading to risk of colonic obstruction. Then considering the overlap in the signs, symptoms and radiographic findings between the Crohn's lesion and the ulcerative colitis, endoscopic biopsies with histological confirmation is often required for the differentiation. Differentiation of ulcerative colitis over the Crohn's lesion. As we have seen, both are sharing lot of common factors. Now, bowel wall thickening ranging 8 mm is more suggestive of ulcerative colitis, whereas Crohn's disease is less than 10 mm. Now, left side diffuse and contagious large bowel thickening is more likely to be ulcerative colitis. Now, backwash ileitis with a dilated terminal ileum resulting from the gaping pastulous ideocycle wall can be seen in both ulcerative colitis and Crohn's lesion and essentially do not help in differentiation. Now, Crohn's disease preferentially involves the right side of the colon and the terminal ileum. Now, isolated left colonic involvement is rare in Crohn's disease. Asymmetrical and segmental involvement of the bowel with skip lesions are characteristics of Crohn's disease, and in contrast to the contagious nature of the ulcerative colitis. Now, coming to infectious colitis. It results from secondary spread of the adjacent process such as appendicitis or diverticulitis, or may primarily involve the large bowel in either immunocompromised patients or immunocompetent patients. Now, here we are considering two entities. One thing is diverticulosis and diverticulitis. Now, let us go into the detail. Diverticulosis is the pathology occurring in the bowel wall which protrudes a certain small diverticuli, and diverticulitis is when it gets infected. So we are going to consider them diverticulosis and diverticulitis. First, the diverticulitis. Diverticular disease is a common in developed countries, with left-sided diverticulosis having more incidence in Western countries, and right-sided are more common in Asians. 50% of the people over the age of 50 years have diverticulosis. Sigmoid colon is most commonly affected in diverticulosis. Of those with diverticulosis, an estimated 10% to 25% will develop diverticulitis, that is the infection of diverticuli. Now, diverticulosis, continuing, is due to lack of dietary fibers, which leads to small stool volume requiring high pressure to move or to expel them. Now, increased pressure in colon leads to the herniation of the mucosa and muscularis through the colonic wall, resulting in diverticulum. Now, what are the complications? These are the abscess formation, because the diverticuli are very prone for the infection. Once they get infected, since they are chronically getting infected, they can just give away and they can either form a abscess formation, colonic obstruction, peritonitis, or a fissurous tract. Then, CT is the primary imaging modality used for diagnosis of suspected diverticulitis. Since the barium examination has got little low sensitivity, CT is extremely accurate. Diverticulosis appears as a small, round or oval or focal filled out portion of the colonic wall with highest incidence involving sigmoid colon. Now, coming to diverticulitis, the affected colonic wall may appear thickened. Now, after that diverticuli are there. There are multiple diverticuli could be present, as we have seen which side is more common in Asians, which common is more common in Westerns. Now there is a possibility of infection. The affected colonic wall may appear thickened due to muscular hypertrophy. Common complications of diverticulitis are abscess, fistula, or perforation. Abscess is identified as air collection adjacent to the affected segment that may contain air or fecal debris. So different varied content will be there. In the outpouching, there will be air and there can be fecal matter or otherwise. The fistulas most often occurring in urinary bladder. It can have a fistula tract up to the urinary bladder and identified due to air and contrast in the bladder, as well as the history will be very characteristic. Perforated diverticuli is identified by small pockets of air of contrast material adjacent to the affected segment. Then frank pneumoperitoneum is uncommon in perforated diverticulitis. Now coming to important colonic adenocarcinoma or malignancy. It is the third most common cause of ulcer related to death. Risk is also associated with polyp size. So it is extremely important to detect the polyps. It is extremely important to detect colonic malignancies because barium enema can lead to the diagnosis and subsequently it is followed by the endoscopy or CT scan for the staging. The risk is also associated with polyp size ranging from more than 5 centimeter and also up to the 2 centimeter. There are different statistics which calls it up to 40%. Now, the other risk factors include diet, genetic predispositions, and environmental influences. Individuals are more often diagnosed between the 6th and 7th decade of the life. So it appears late in the life. Depending on the cancer's location, the initial presentation will differ. Now, these include ascending colon, transverse colon, descending colon, and rectum examination. The appendix and portion of a small intestine may also be included, if possible, if we can push barium up to the terminal ileum and beyond it. The lower GI uses fluoroscopy and barium as a contrast medium. Then fluoroscopy allows visualization of internal organs and peristalsis. Now, from here we'll be seeing actually cases. Now, most of the cases, let us see, certain pathologies are covered, but we do not say we have covered all the pathologies. We have got different series of the examination where we are different pathologies are shown. There is also a series which only concentrate on the role of barium as a contrast medium, and in this we are talking again barium enema by using barium. So there is some overlapping between the two lectures. Now here what we are seeing is the contrast is going from the rectum into the sigmoid colon and then into the splenic flexure, but after splenic flexure we have got a coil spring appearance. Take 1 or 2 minutes to analyze the films, tell the diagnosis. It could be into susception. So earlier barium was used to reduce it, but nowadays we are preferring ultrasound for diagnosis also and for therapeutic reduction also. This has come from our earlier studies. The large filling defects can be there seen in the barium studies. Now once you see large filling defects, what is the most common cause is the fecal impaction. Now you have to see whether it is consistent. You have to see how it is coated. You have to see in different angles, and once you are convinced it's a colonic lesion, then the differential follows, which are polyps, tumors, Impacted fecal matter and foreign bodies we have already ruled out. But please note, this is a big size polyp and there are very high chances that it could be malignant. So further examination are mandatory from colonoscopy and biopsy for detailed evaluation. Now, as I told you, you have to take multiple film to show the consistency. Now again, we are coming to the pathology which we had discussed. There is a partial obstruction, coil spring appearance involving adjacent region of the hepatic flexure. Now the top of the list is the Hirschsprung disease because of the appearances. Now this is how you have to do your technically correct double contrast examinations. Now these examinations are required for earlier diagnosis of ulcerative colitis. You should have a clear air contrast picture of rectosigmoid region and you have to see the mucosa so that you can appreciate the pathologies. Now, this is what happens. The barium enema we are using when we are doing a large intestinal studies. Large intestinal studies can also be done by barium meal follow through. But the advantage of barium enema, what we are emphasizing are you are not seeing overlapping small bowel. Now, this is because we have done a barium meal follow through, we are seeing lot of overlapping small bowel. Now, here we are seeing a non-distending segment. Non-distending segment with shouldering. So, top on the list, diagnosis should be malignancy. Now, these are few more cases where, as we have emphasized, you must take air in the region of pathology. Then only you can get the proper details of the mucosa, shouldering, apple core appearance, and a malignancy. Often it is important to note how much is the length involved and what are the parts involved. Now, this is another indication where either we can use barium or we can use a water-soluble contrast. Now, these are the large bowel studies which indicates that there are certain narrow segments of the rectum, number one. But number two, what is more important that is look at the position of cecum. Cecum is displaced medially and there are possibilities that it can be a case of malrotation. In that cases, again, we have to do barium studies to see entire small bowel. Here again, we are seeing certain non-distending segments, different cases. Pathology is same. Though the cases are different, the pathology is same. That is the malignancy. Here also we are seeing a malignancy of ascending colon. It is a single contrast seen in the ascending colon, but it confirms that it is not distending, there is shouldering and a narrow segment. Now you can see there is non-distendability, number one. Number two, reduced lumen caliber. So called a rigid tube appearance, and your diagnosis should be ulcerative colitis. Now here see at rectosigmoid junction, again you are finding a pathological lesions. Now, barium enema at time may not give you a histopathological diagnosis, but you can of course suspect and give a differential in these cases, as the top on the list should be malignancy. Here there are few more pictures which you must diagnose. We have seen this pathology. This is into susception. Now, there is an application in large bowel pathologies involving anorectal malformations. In that, top on the list is congenital megacolon. Now we are going to see multiple cases where there will be a narrow segment at anorectal junction It could be a ultra short segment, it could be a short segment, or it could be a long segment. Now we are going to quickly run over the series since the pathologies are self-evident. When we are dealing with anorectal malformation, when we are seeing there is a dilatation of colon, the doubt comes as whether it is really a ganglionic segment that is causing problem or it is a chronic constipation. So in this type, one of the indication from radiologist is to whether a pediatric surgeon should go for a biopsy or not. A special modification is done in the technique that 24-hour film is also obtained along with this, and we see whether barium is retaining or not, and depending on the circumstantial evidences, differential of either chronic constipation or anorectal malformation is considered. Right from the plain X-ray, you can see the diagnostic features of the congenital megacolon. Different cases, different varieties. Pathology is same, that is the anorectal junction. Some varieties may differ. Again, another case of congenital megacolon where we are seeing a dilated colon and a narrow aganglionic segment, which is also called a zone of transition. We are labeled CMA is congenital megacolon, but again in certain cases you have to keep in mind differentiation of chronic constipation. Multiple cases showing different varieties. The distension can be as massive as this if the obstruction is very severe and your child comes little late. So much can be the distension. Then entire large bowel can be aganglionic, or it can be a small disused large bowel. When it occurs is when there is a impaction at or atresia at ileum or other small bowel, the large bowel will remain as a disused and it will remain a small. So these are the two variants where we can see a purely aganglionic entire large bowel, that is long segment Hirschsprung, or acquired, that is because of the proximal obstruction there can be a microcolon which is a disused. Now we are seeing here megacolon, long segment Hirschsprung, different cases but the same pathology. Again here the pattern of the small bowel can be, so the pattern of the large bowel can be seen, which is slightly unusual, and that also indicate there can be a malrotation in addition to. See here where is the cecum, where is the splenic flexure, so definitely a case of malrotation. Now there can be redundancy, it can be of excess length, it can be mobile, it can cross from left side to right side. And pouch colon is also a variant of the congenital megacolon or anorectal malformations. These are the cases. This is again a case of microcolon, and here also we are seeing same. Now after the congenital megacolon we are coming again to the malignancies. Different cases of malignancies we are seeing here. There is non-distending segment, shoulder ring, this is the long segment Hirschsprung, where you can see that the rectum has got a long segment of aganglionic portion with proximal dilatation. Again a case of malignancy, you can see clearly apple core deformity, then narrowing, again more cases of malignancy, again more cases. Now this already pathology we have discussed, it is the congenital megacolon. long segment, Hirschsprung. Malignancy, colonic. Core deformity is there. Now, one of the application of the barium enema is to see ideocycle junction where it is located. Now, ideocycle junction can be at a normal position or pulled up. When there is a contraction of cecum and pulling of the ideocycle junction, we often tend to put it as a tuberculosis, looking at the contracted, truncated cecum, pulled up ascending colon, straightening of ideocycle angle, and some changes in small bowel, which we are seeing here. There will be multiple strictures in the ileum, so also mesentery will be adhesions. With this, now we come to the end of this lecture series. We are going to have, as I said, multiple series. Every series will have some other different diseases, and it will discuss about certain different techniques and pathologies. In this, till now we have seen, is there any role for barium enema, or it is an investigation which is washed away in the timeline. Personally, if we judiciously select the cases, still there is a role for barium enema, and it can give good information, but it is also true that it is technically difficult and the skill is getting lost as the days are going because it is not used frequently. I thank you for giving me your valuable time. Please note, radiology is not a race, it's a process. Be a part of this process and enjoy the feast of knowledge. I am Dr. Anil Joshi, logging off till we meet again. Now in this we have seen a technique which was once upon a time very popular when there were no ultrasound, when there were no CTs and there were no MRI. This technique was doing majestic job for detection of the malignancies. So it is important for newer generation also to know the older technique, so what good it was doing, and in case if there is any indication for it, we should be able to do it and we should be able to get it. With this, thank you, take care, do your best to the patient, and be a part of investigation team to benefit patient with the surgeons. Thank you.